Okay, I think we are live. I'm trying to check too many screens here, but I think we're good. So welcome everybody. If you're tuning in right off the bat, I'm Jeremy Butler. I'm the Chief Executive Officer of Iraq and Afghanistan Veterans of America. Appreciate you tuning in. I've got a very exciting event for you all today. It's really timely. I would like to say that we knew where things were going to be with COVID 2 months ago or so when we first started planning this, but I think our timing actually worked out surprisingly well, I guess. I don't like necessarily saying it that way because things are not where they should be, but hopefully we can address some of that today. So again, I'm Jeremy Butler. I'm a Navy veteran. I'm the CEO of Iraq and Afghanistan Veterans of America. Really excited to have with me two incredible guests. I'm going to introduce both of them relatively briefly, and then we'll jump right in. I think most of you probably who are joining us are familiar with Bob Woodruff's story. He was reporting in Iraq for ABC World News Tonight in 2006 when his vehicle hit a roadside bomb and he sustained a life-threatening traumatic brain injury. He spent 36 days in a medically induced coma. And this started he and his wife Lee on a journey that really brought them incredibly close to the families of service members dealing with the impact of war. In short, it inspired them to start the Bob Woodruff Foundation to ensure that our nation's impacted veterans, service members, and their families have access to the highest level of support and resources they deserve for as long as they need it. Bob, welcome, and most importantly, thank you so much. You and the Bob Woodruff Foundation have been an incredible friend to not just IAVA, but our entire veteran community for so long. We thank you for all the work that you and the foundation have done and continue to do. So a big welcome to you.
Well, thanks, Jeremy. We've been close to the IAVA for a long time. It's great to be in this great partnership with you guys.
Exactly, and we'll talk a little bit more about that partnership. Also with us today is Dr. Kavita Patel. She's currently a primary care physician and a non-resident fellow at the Brookings Institution. She has an extensive understanding of the inner workings of Washington, D.C., having served both in the Obama White House as well as on Capitol Hill for the late Senator Edward Kennedy. And she's also our first repeat guest. I feel like that's kind of a milestone in pandemic time. We started doing these events right after the pandemic started, and we all kind of went into lockdown. And Dr. Patel joined us back in February to discuss the pandemic, and she also joined us with Veterans Coalition for Vaccination and Team Rubicon founder Jake Wood. So that was a great conversation. February seems like a long time ago, so it's great to have you back here again. Lots has changed. I'll try and speak correctly since then, and I think we're going to get into all of that today and more. So as always, we'll be happy to take your questions. If you have any questions, we've got folks working on the back end. Just drop your questions, comments, thoughts in Facebook, and we will try and address them as we go. But let's jump right into it, Bob. IAVA and Bob Woodruff Foundation, as you said, we've worked together for a long time, but had this partnership that started anew recently around the pandemic and the vaccines, and our efforts to really make sure that not just the veteran community, but kind of a special emphasis on the military and veteran community are getting the care and the support that they need, as we always do. I will throw it over to you. I'm not sure if it's on my side, but it looks like a little freezing of the screen. There we go. We're back again. So let me kick it off with you, with maybe just any thoughts and comments on sort of where things stand and what's going on with this pandemic and the community.
Well, it's kind of hard to believe this was January 2020 now. This is hard. We never expected this, Jeremy, as we all know. It's interesting that I was over in the Philippines doing a story about the volcano that had just blasted over. That was January of last year, and this thing is just starting to emerge out of it. And I got this phone call while I was down there from our Asia team, and they said, "Listen, there's this new coronavirus that seems to be emerging out of China, out of this little town, or this large town actually, of Wuhan." And they didn't really know much about it, but they said, "Can you come down to Hong Kong and start reporting about what's going there?" And I mean, this was Asia. They're used to wearing masks. They'd gone through these kinds of situations before, and suddenly they got this brand new one. Only about half of them in Hong Kong were wearing masks even then, even though the story was starting to go around. And so from Hong Kong, after reporting for about a week, I decided to go through Wuhan, where this thing was beginning. And I just went to the airport there just to see what the people are doing. And they're just pouring out of the city of Wuhan to try to get out of the town. And then I got back to the United States. And then I just went straight to the office after about 5 days of having no symptoms at all. I went to the office and we're starting, well, you should be coming to the office. And I said, I don't know. I didn't have a symptom for 5 days. I'm told that I'm safe. We actually contacted Dr. Fauci and we asked that exact question. He says, well, if he's had no symptoms for 5 days, he can still come to the office. We could have thousands of people in America that can't go to the office if we start to follow that kind of model. We didn't wear masks. We didn't really know what to do next. And we had no expectation that we would get a vaccine as quickly as we did by the end of that year, with mRNA, which was the remarkable, miraculous kinds of vaccines, especially with Pfizer and Moderna. And so that was starting to happen. Then we realized that, we started to study from the foundation side of this, from our foundation, is we wanted to see how this is impacting the veterans. And we saw that there was a significant impact on veterans. Part of it, of course, is, age, a lot, those from like the Vietnam era, there's a lot of seclusion, there's a lot of unemployment. And there was actually released a research paper back in April of last year in 2020. And when we really found that this was in that research, it looked like a perfect storm. The veterans are going through these kind of mental health issues and job loss and a lot of and food security. So all last year, we concentrated completely on COVID and how it's impacting the veterans. And that's the way it was. More than $6 million we helped to fund some of these organizations out there. So now we've got more variants. Now we've got Delta. So that's sweeping through the world. That could change things and make it, have it come back again. Well, let's hope not.
No, that's excellent. That's a good summation kind of things. And you touched on a couple of things that I want to continue to talk about. One certainly is the scope of the impact. It's really not just the pandemic and those health effects, but all the trickle-down effects and related effects that go along with it. But you also touched on something else, which was in the beginning, we were getting the guidance, I will say, the best guidance I think that medicine had at the time. And Dr. Patel, maybe I'll throw this to you because we do want to get into some of the misinformation and disinformation and things like that. Obviously, the guidance has changed from back in January, February, March. Is that normal? And maybe we could start there by talking about the evolution of the medical guidance from the beginning of the pandemic to where we are now.
Yeah, thanks, Jeremy. And thanks for having me on as a milestone repeat guest. I'm hoping the next time I'm a repeat guest, it's not about COVID. And we can talk about some of the also very important pressing issues affecting veterans, including mental health, access, and kind of thoughts to prevention. And so that is what I'm looking forward to. But to your point, I actually was reflecting, just probably like Bob had, I kind of was looking back on emails and other back and forth with colleagues. And I had a very kind of long email chain in January of 2020 with a Chinese colleague, not in Wuhan, but in Beijing. And she was telling me, this is real, I think. And she made the point, I said, so do we know, and I was in the White House during H1N1 and kind of present with SARS-CoV-1. And I said, are we dealing with something airborne? I said, are we dealing with something that we know kind of what the spread is? And I think three things. One, this was novel, and there was just a lot about the virus, despite being able to genetically sequence it pretty quickly, that we did not know. And then number two, I think that we acknowledge now as public health communicators, and Bob, you're brilliant at this, that, it's a fine balance between kind of communicating very, I don't even want to say complex, just nuanced public health messages to a public that, you don't want to overly kind of scare anybody. And I think that conversation you had with Dr. Fauci is reflective of that you try to do not just the most conservative thing, but you also try to do what is in the best interest of a large population. And at that time, and I will say, we've talked a lot about social media and misinformation. There's actually been, if you want to acknowledge, there's been ways that social media has been good and challenging. We wouldn't have had some of the challenges to some of what the World Health Organization had been saying around masks, for example, which is, I think, Jeremy, your point. In March of 2020, we were still following the WHO's recommendation, which is that only people in kind of high-risk settings needed to wear masks. And then we also wouldn't have challenged some of what we now acknowledge with China, that there were, and I don't even want to get into lab leak or, kind of gain of function for like research, but I think there's been a role that social media has played. Having said that, the ease with which now one person, me, can kind of literally become as relevant of a publisher as Random House, because I can put something and it can go viral on the very platform that we're on, is really serious. And I think that's the problem we have. So, and let me just give, I think since I'm a doctor, I have to always think about how I communicate about this. You have to give people something positive. It's really hard to kind of talk about populations, and even with the Delta variant, it's so hard to talk about, now we're going back to mask mandates. I've been asked on TV, are we going to have to do lockdowns? It is I can't get 100 million people to get vaccinated if all they see is more doom and gloom, and acknowledging that is real. So what I will say is that if, even though we're talking about something very serious, cases are rising, people are dying, and we're all worried about kind of breakthrough. Is our vaccine that I took good enough right now? I will say there's just an incredible amount of light. We're coming out of this, and it's not just a tunnel. We're in, there are many parts of our country where you feel the sunlight. Why? Because I've got 85-year-old patients who won't die. And even with this rip-roaring variant, they will not die because of that vaccine. And I can't think of a time when America shined more. So I will say, for all of its criticism of administrations, politics, and America not having a national health system, I can't be prouder. And it wasn't American scientists, but it absolutely was an American kind of leadership and funding and research and priorities that got us to where we are today. And we have to actually be proud of that.
No, I think you're absolutely right. And it is tough sometimes to not focus on the negatives as things change. I'm here in New York City. I was here for the start of the pandemic, and that was when things were really, New York was one of the worst spots in the beginning. Then we kind of came out of it. It spread to the rest of the country.
Right.
We saw really quick vaccination rates go up really high. Things are opening back up, but now, we're seeing the rest of the country suffer. But now rates are going back up here as well. So it is tough to remain optimistic and focused all the time. And so maybe that's a good point to jump right into to one of our main things, which is vaccination hesitancy, and what we can do to get more people vaccinated, and really maybe address some of the reasons why people are not getting vaccinated. And I know, Bob, you're seeing that from the Bob Woodruff Foundation side. So maybe you want to start with whatever part of all of that I just said that you might want to focus on, either vaccines, hesitancy.
Yeah, I mean, hesitancy is one.
The other issues that.
Yeah, the hesitancy has been a very big problem right now that we have in the U.S. I think the hope was that we would have almost everybody wants to get vaccinated, especially given the science of it, the proof of it, the remarkable program that was launched to try to do this as quickly as possible under the direction. They worked out masterfully and came out with a vaccine that worked. And now it is proven that it will work against any kind of variants that are now coming out. So that story of hesitancy is one that still, to many people, is hard to understand, except we do know that it's, people just have a lack of trust. People have fear of taking a vaccine, even though most of us have taken vaccines since we were little babies. But another brand new vaccine, people are afraid of it. There's politics involved in all of this. And some people just don't have the ability to get to the clinics, whether they live far away from the urban areas, or they're homeless, or may have disability, they can't leave their house. So we're finding that there are amazing organizations that we've got in contact with in our existing network that we have. We have about 100 local partners around the country. There's, for example, there's one in New York City, where they try to bring the vaccines to those that are homeless into their houses, or those that are in their houses, trapped in their house, also out on the streets where they're homeless. Virginia, there's a free transportation to clinics program that they've got, so they can try to get this to them, to those that are elderly or with disabilities. And then in Houston, through the Combined Arms group, they hosted this thing called the Snacks and Vax, which is combining together this idea to bring vaccines to them and also food, to put these different problems together and try to serve them all. Because we do know that sometimes if it's just a vaccine program, sometimes people do stay away. But if you give something else that you're getting for them, something else you want to help them with, then they bring them up and they say, oh yeah, also there's a vaccine here. That would be great too, because, even North Carolina, we've also got another program that we help to fund, which is, getting vaccines and employment advice at the same time for people that are largely homeless. So if you put these things together, sometimes that helps. This is then you can give people money. You give them free donuts, or Uber has given free rides for people to try to get them to the clinics to get vaccines. So I think that's a very important part of all this. People will trust their local communities more than they will any programs from far away, from outside. So I think that's been very effective.
Absolutely, and I also want to add, because it was being pushed, and then it kind of was put into place around the time that vaccines were becoming pretty widely available. So I don't think it kind of got as much notice amongst the veteran community as it should. But now the VA is providing vaccines to any veteran, regardless of if you're enrolled in the VA or not. Also, spouses and caregivers all can get a vaccine through the VA, and for many veterans, they trust the VA. Many don't, certainly, but it is an available option for every veteran. And so I just definitely wanted to add that into, that the VA is there and they're pushing the vaccines quite a bit as well. Dr. Patel, any thoughts on the hesitancy and where maybe some of the groups are that we should be focusing on? I'll know very quickly before we start. When we first talked back in February, I know we talked a lot about the minority community. I feel like at the time there was the thought that was going to be where there was maybe going to be the biggest hesitancy, and then it kind of broadened unexpectedly.
Yeah, I do. And I think, by the way, what the Woodruff Foundation is doing to kind of have more of these very practical community-based suggestions, tools, ideas. So I go on the website. There's some great tips and tricks for community leaders. And that brings me to kind of the point you mentioned. There's no question that you're going to need to get local. So, someone they don't know, kind of talking through this isn't going to necessarily engender the kind of trust that we need. So who can do it? Not always health professionals. I know that people tend to trust me. My own patients tend to trust me, but I'd be arrogant to think that when it comes to decisions and changing behavior, I make the analogy to what I saw when we were thinking about HIV prevention or smoking. And you really have to get people at this crucial time. For example, with smoking, and I did part of my time in medicine and training at a VA, and that was one of the most important times. The best time to get someone in a smoking cessation program was actually at the time of hospitalization and discharge. So even though it might have nothing to do with their hospitalization, getting them in that moment. Same could be said about COVID vaccines and coronavirus education. You got to get people when they're kind of in a moment and they have the ability to see that some little behavior change of 1 degree can make a huge difference in their life. And that can be done with, maybe you have donuts and drinks and then all these people are gathering. Maybe it's something like this on Facebook Live, but someone's commenting and they see someone they know and they're like, oh, this person comments. So it's going to have to be local. And Jeremy, unfortunately, because it's got to be so local, we're not going to see these dramatic numbers kind of right off the bat. And so just my little tips and tricks, I see a lot more. And to your point, we do still see higher pockets of persons of color that are not getting vaccinated. And that just echoes what we did talk about in February, where there were huge disparities and clear trends of communities of color being disproportionately affected, meaning dying and getting infected at higher rates than they reflect in the population. So my little kind of toolkit of tips and tricks I use with my own patients repeated messaging. So I don't shame, I don't blame. I treat the vaccine status like a vital sign, just like I would their blood pressure, their weight, their temperature. Did you get vaccinated? Yes or no? Okay. And then move on. And then I kind of circle back and then I say, hey, by the way, do you have any questions? You know, no pressure. We've got the vaccine here. Do you have any questions? Number two, repeat doing that over and over. Number three, enlisting someone they trust. For my 25-year-old female patients, who are worried about it affecting their DNA and their fertility, if I can get their grandmother to kind of talk about, you know, how scared they are for their 25-year-old granddaughter, that'll have a huge dramatic shift in that moment, in that behavior change, in that conversation. So find those moments that make a difference. And for veterans, since I know we have kind of anybody watching, listening, I think the most important thing is to also remember that for veterans, not only is it available for everyone, this is, I think I have seen so many veterans who have other chronic conditions. So I would say, not as a blanket statement, but veterans are at a much higher risk of having worse outcomes if they do get infected, because we do see higher rates of everything from diabetes to heart disease to PTSD to lung disease that directly had a lot of relationship to their time in service. So I do think it's important to point out that, you know, for a 47-year-old veteran who, you know, doesn't necessarily seem like they're sick, they might have a much higher risk of ending up in the hospital and dying. And that's, I think, a story that we have to learn how to tell a little bit better without scaring people. Some of my colleagues have advocated to like just, you know, slap up pictures of like lungs and kind of, you know, people dying. I think Americans have seen that. I just don't think it's changing their minds. And so we need to figure out how to do that. And hopefully being honest. By the way, the most honest conversation I had with a patient where I changed her mind is when I said, you know, I would also be a little suspicious if the government got a vaccine out in like 9 months. Like, I get it. Like, I see why you think that's like a little weird. The government doesn't do anything fast. And here we are with this magic vaccine. So I think it's also like kind of saying, yeah, I get it. Like, and, you know, and I'm a woman that still might, you know, want to get pregnant. And if there was any chance this harmed my baby or my ability to get pregnant, hell no, I would run the other direction. So I think part of that is to kind of say, like, it's okay to say that this might have been a little, like, yeah, it does seem a little fast, right? Like, it seems like they did it faster than they've done anything else, because that's just the real world that we're in.
You know, I think, I don't know if you saw the same thing, but because of this resistance to this, people who don't want to get the vaccines, I think we're seeing, and maybe this is going to be the case, that because of this emergence now of the Delta variants, and now you're seeing this going, just sweeping through the community again, and making people sick, but not killing them unless, of course, they have not been vaccinated. I think there's been a slight wake up to some people that have been against it. You know, we're seeing, like, you know, just watch, you know, Fox this morning, and they're coming out very strongly. We listen, 99% of those people that died last month alone were those that didn't get the vaccine. Everyone's completely agreeing with that now because they're seeing this is clear, and it's so black and white now. It's so clear. For example, in what I read yesterday was in the month of June, 140 people, I think, died in Maryland because of, and that was 140 of those 140 were those who were never vaccinated. So people do get, they get the COVID again if they've been the vaccine before. We have seen that, but they're not the ones that are dying, and not even the ones that go to the hospital, the ones that get sick. So I think this is starting to change. And if the veterans who are hugely influential in these kinds of the hope that they can convince those to get the vaccine, is there was a Pew Research study that said that Americans actually trust the military and vet communities more than they do than politicians, CEOs, I can only assume journalists too, and also even scientists. You know, so they're very believable in people's minds, especially, of course, within the veterans community itself. But even Americans, I think that if veterans are doing it, I think people are more likely to believe it, and that's crucial for what everybody is a veteran out there.
Absolutely, and that's why I appreciate you both doing this and coming on here, because we're trying to do that. And to your point, Dr. Patel, trying to educate and inform, not shame people by any means, because that's certainly the case. And it really does. I think it's proven that that's not helpful. We have to get more information out there about what's going on. Along those lines, could either of you maybe talk about the booster shot now discussion that we seem to be having while we're still trying to get people to get their first shot? I don't know if this is a discussion that is helpful or not helpful. I hear sort of thoughts on both sides saying we shouldn't even be talking about it when we're still just trying to get people their first doses.
I'll start with kind of what the data tells us. The data supports that certain populations might need, and let me be kind of also clear, there's probably different ways we're talking about booster shots. The booster shot I'm talking about is the third dose of the exact same thing you got for 1 and 2 of an mRNA vaccine. And then there's also a booster kind of that's tailored and developed and tweaked, if you will, from the original formula to deal with variants. And so that's a separate kind of process, which might end up being what we all do, by the way. Like we all might end up getting something around Christmas time or the holidays, because we might all need a different kind of vaccine, just like we do the flu shot every year. But that conversation, Jeremy, this Thursday, in 2 days, the advisory committee to the CDC is going to sit down and talk about the evidence available for recommending boosters for what we would call high-risk populations. And it's very reasonable, and I've been practicing this. I've seen the data in my own personal patients who have an organ transplant, who have certain immunocompromised conditions, and frankly, some of the ones who were dying at the higher rates earlier, nursing home residents, people over the age of 85. I hope that Thursday will come out with some clearer guidance around those individuals getting potentially a third shot. And then there has to be a little bit, all three of us are kind of international in our expertise and domain. Brings up a lot of really appropriate questions about vaccine equity, because part of the reason we have the Delta variant in existence is not only 100 million Americans who are not vaccinated, but billions of people on the earth who don't even have a vaccine right now or access to it. And so the virus isn't smart enough to selectively go into a population. It just wants to reproduce and live, and it does that by replicating, and thus it mutates. And so the booster conversation, if you're watching, listening, and you're wondering, do I need a booster? I would actually kind of, take that conversation to a physician. And if you're especially in one of these populations where you have a compromised immune system, lupus, rheumatoid arthritis, someone who's had an organ transplant, someone who has also had previous issues with mounting an immune response to other vaccines, and certainly people are at a higher risk, what we'll call elderly over the age of 85, and even certain healthcare workers. I got my vaccine series kind of when it rolled out in December. Many of us are wondering if we need to be in that population. So I would tailor your concerns about a booster to select populations for now, with an eye towards, I think, all of us expecting some additional vaccine, but probably of that tailored variety, and probably, let's call it late 2021, early 2022.
Yeah, I mean, if I could just add in too, when you talk about how the billions of people around the world that do not have access to the vaccine, and it's pretty stunning. I was going to, like Haiti, for example. I was actually about to head down to Haiti because for the first time, they were going to get their very first vaccine, which I was going to go down with UNICEF, because UNICEF was going to haul it down there themselves. And it turned out they did, actually, a few days ago, and US military planes to get them in. And we are so blessed in our country to have the ability to have these vaccines. If you don't want to take it, of course, everyone's got the free to do that, but you just have to remember that people are desperately fighting to get these vaccines around the world. So so if we get another round of it, for all of us to get a third one, I don't feel guilty about it, but the percentages are stunning. We are about maybe 15%, like the wealthiest countries in the world are about 17% of the population, the 5 wealthiest countries, and getting about 57% of all the vaccines. So the numbers are pretty stunning, and we have the ability to do it. So, it's kind of nice to have the chance to do it. And I think you're absolutely right on that. A third one, let's do it if we really do. But, if it's going to help our country to keep from entering into another crisis, then that would certainly be important to us.
Well, and I think that also touches on one of the parts about education, and that's that, you know, for those that are reluctant to get vaccinated for whatever reason, they should also be considering the societal good of it. And that goes back to the variants that, you know, it's not just about protecting yourself, it's about protecting those around you and reducing the chance of more variations arising and spreading, et cetera. And I keep forgetting to do this real quick. I'll throw it out again. If you've got questions, comments, please do put them in into Facebook. We'll try and address them, especially if you're out there and you're hesitant and you've got a reason to be hesitant that we haven't addressed yet. Love to hear from you so that we can talk about it. Maybe another issue going right along with that timing is thoughts on when and how it might change when we get FDA approval, assuming that it does happen. I feel like it is an assumption that it's going to happen, but maybe I'm wrong there.
And you can do that.
Sorry, yeah, I keep not specifying, and that's not useful on these types of things. But Dr. Patel, you want to take that one?
Sorry, do you want me to take a first crack since I lived FDA policy for a lot of my life? So Pfizer submitted their kind of what we'll call BLA, full licensure application in early April. Now, because this is such a high priority, the FDA puts it into kind of a rapid, like accelerated track for consideration. But the application is literally thousands of pages, and the FDA has an obligation to kind of review every single page and to go through their process. They have kind of a time stop on how long these rapid processes can take, and it's, I have to remember if it's 9 or 12 months, but it's not years. However, this is obviously a global priority, and we know that some people are hesitant because they don't have an approved vaccine. The difference in nuance between authorization and approval is really just technical designation, just to let people understand that we have all the data we need. It is fully expected that Pfizer and then Moderna has also submitted theirs, that Pfizer and Moderna and Johnson & Johnson will receive full approval, even with some of the clinical warnings that have come out, blood clots in particularly younger women, younger like men, and inflammation of the heart. Those are important, but do not outweigh the benefits. So when will it happen? That's the $1 trillion question. Many of us who've worked kind of within and with the FDA, we do know that they're prioritizing this. So 4 months, 5 months after those applications are submitted, not in time for my children to get it when they start school, but hopefully in time so that, and children's vaccines are separate, by the way, I should make that clear, but hopefully approval kind of, you know, in time for Labor Day of return to work, kind of reopening. And that'll, what I worry about though, Jeremy, is that I think that'll help like maybe some employers who are thinking about having a requirement for the vaccine. I'm not so sure, it might change some people, but I'm not so sure it's going to change 100 million people. Of course, some of those people are kids and they're not eligible yet. So I think we're going to need to continue to do kind of the things that Bob's advocated for, that IAVA is talking about. But yeah, we should see that soon. And then it'll be a rolling wave of approvals. And I would expect we'll also see some new entrants. Remember, it's not just the 3 manufacturers. We've also seen incredible data, and the government, the United States, had negotiated contracts with dozens of manufacturers. So I think we'll see more and more choices that also might allow for people who are hesitant to feel more comfortable. So I think that's on the horizon. But I'll be honest, I'll say it bluntly, Jeremy, I did not think the summer would have this level of viral activity. I thought because this is a virus that tends to not love warm climate, I thought that when we'd be having this conversation would be in the fall. I was expecting the October, November timeframe. This rapid acceleration of this timeframe is a reminder that when we think we know what might happen, we don't. And so it's all the more reason for me to urge people who might be waiting for quote full approval to realize that the difference between authorization and full approval is a technical one. We have everything we need to feel comfortable about the safety of these vaccines.
Yeah, you know, things have absolutely changed. This is extremely, you probably know this, this is an extremely rare approval because we were so desperate in needing this thing to be given the okay to use these vaccines that we had about 40,000 people that were tested to see if it was safe or not. We got the okay at the end of last year. And now we have 100 million now that have tested these things to see how good it is. So, and so far, like you said, there's been little tweaks here and there, some little problems here and there, but incredibly minor. And so it's been proven. I mean, this high technology makes these safer than everyone had thought. It's determinable so much faster than any other vaccines before. So hopefully that will encourage people to really want to do it. But like I said, Delta's now changing things, as you said too. It's much worse than we thought it was going to happen, in the sense how the speed and how the impact was. Is that I think now people are seeing there's changes in their lives. They thought those things were over. I remember we saw it, the economy, we saw the market crash yesterday by more than 2%. I think people kept thinking this was going to keep going up. If there's going to be a crash, it wasn't going to be related to the virus. It was not going to be COVID. It was going to be something else. But now that went down. It went up again today. I just had to check again. It's like another, like Dow's up 1.2% today. So all right, so that's good. So it just keeps going up and down, and that's what people don't want, that either. And then we got all of our kids. I got two twin little girls that are their senior year in college this year, and they've been denied a year and a half of to have a really decent college experience, and now they got their final year. If we have, even if they're not people dying from it, that people are getting, if people are get COVID, even if it's not killing them, if you get a positive case, then the school's going to close down again, or things are going to change completely. So I think that's hopefully is going to change, and maybe giving the final FDA approval, hopefully that will give people a little bit more of a push to do it.
And I know there's certainly talk in other areas, but since we're, probably talking to a military veteran community here, there is definite talk, and all the service chiefs have really been talking about, and not just recently, it's been going on for a little while, that the expectation is that once they do get full FDA approval, that they will become mandated for the military. And I know that's been a debate up and down as to whether or not the Department of Defense should do that. But I think at least the Navy and the Army, I think, have their chiefs have publicly said that they haven't said it's going to happen, but they've all but said that it is very likely that once they get approval, it will become mandatory for them. And maybe also within the VA for veteran-facing staff, there's discussion about that as well. So hopefully that does spur some confidence and also get some more people vaccinated as well. I think that would be really important. Let me pause 1 second. Victor, do we have any questions or anything that you want to throw out?
Yes, sir. I do have a few questions.
Oh, great. Fire away.
This first question is for Mr. Woodruff. Mr. Woodruff, your foundation is such a trusted organization in the veteran space. How are you leveraging your trusted brands to get more people vaccinated?
With the foundation, how do we do it? I think we just, like, as I said before, we have a pretty good network of 100 different organizations around the country that are trying to help on this topic of COVID. And if we can find support for them and get some funding for it to keep them going, we really are hoping that those in your own neighborhood can make sure you give all the information and then give the access to it, whether it's by vehicles or getting into the clinic or getting more information or help with all sorts of other topics. So I think the way to do it really is, I think what we're finding is just get people telling people, not necessarily to have announcements or to read something in the newspaper, because I think people are getting the same information and they're kind of overwhelmed by it. But as we know, and anybody in the world of marketing, they know that a human contact is way better than any kind of emails that you're going to get, or even a phone call. So I think that's we're learning.
Thank you so much for that. This next question is for Dr. Patel. What can you share about concerns for women who are pregnant or who plan to get pregnant? Are there unique factors to consider with getting the vaccine?
Yeah, great question. I deal with this a lot, and I'm just going to say I'm trained. I'm a primary care physician, so I have done a lot of this work with close consultation with my obstetric gynecology colleagues. So number one, we now have incredible evidence about the harm to a pregnancy from a COVID infection. Everything from premature birth and some questions about kind of outcomes of the baby itself. So I would just say that we know a lot more about how COVID affects pregnant women differently. Second, I just want to make sure this gets said. People often see mRNA and it's a lot like DNA, and they just kind of assume that that means, you know, there's some changes to your DNA. And of course, a pregnant or a woman who wants to become pregnant is going to be concerned about that. There's no interference. In fact, if it makes anyone think about this differently, the reason they're called messenger RNA is because they literally deliver a message to your natural body's immune system. And then, like a messenger that gives you a FedEx package, they leave. So there is no signs of this mRNA vaccine even hours after administration. So for pregnant women, I think it's incredibly important also to know that if you do get the vaccine, especially during second trimester or even earlier than that we know those antibodies that you're developing, like other antibodies that the mom has, pass on to the baby. And I think that's important because we talked about the fact that we don't even have an eligible vaccine for children under 12. So think about it this way, that actually getting this protects you, the mom, but also protects your baby. There has been, to this date, there have been no associated incidents of deaths or premature infections or miscarriages associated with the vaccine. But let me be clear, there are women who have had the vaccine who have had miscarriages, but they're not, and problems, but they're not at a higher rate than when you look at the population of people who have not been vaccinated. So I say that because I can find on like the CDC database that a death of a pregnant woman or a fetus could be in that woman could have been vaccinated, but nothing is happening at an increased rate, meaning we don't believe the vaccine is linked to kind of that horrible, tragic outcome, that it's something else. And so I would say that for all my pregnant patients and for even me in particular, personally, I felt like the risk of what could happen that could go wrong with getting COVID, and there's now some very small but global data that shows that for men as well and women, that COVID infections can lead to increased infertility. So for all those reasons, that data stacks up that the vaccine's benefits outweigh any of the risks. And that's safe, by the way, also for breastfeeding women. Just wanted to say that because it's a concern all of us have when we are pregnant or have a child, a newborn, and we want to keep them safe.
Thank you so much. This next question is about misinformation. Where is all the misinformation coming from? Is it coming from one specific source, one specific way of thinking? Can you talk a little bit about that? This question is for everyone.
Yeah, I hope it's not coming from us that have, we have kind of a different process when we report that's very different than social media, is that we have to have multiple sources and we have to check things before they go on, because if it's in the old days it was government regulations that we couldn't just spew things out and make it up, and there'd be all sorts of lawsuits that would be launched at us if we did that. And then social media came out and there's no such thing as a lawsuit against anybody that gives back bad information. They don't have any sources at all. And people really, there's so many pieces of information and storytellers out there that it's impossible to know which ones are legit and which ones are not. So in that sense, it's quite clear where it's coming from, because you're not really getting terrible misinformation in the main programming from both the right or the right, or the left or the right, whether it's like a CNN, MSNBC, or Fox, or, we're kind of falling somewhere in the middle at ABC and NBC and all that. But I think you're probably getting most of this misinformation from social media.
Yeah, and there was an interesting study. The United States Surgeon General has just kind of put out what I'll call like a national call to action against misinformation, specifically around COVID. And there's a very interesting publication. It's on if you go to hhs.gov and just kind of search in there for Surgeon General, it'll come up. But interesting study that was done between the United States and the UK. And they found that a large percentage of the sources of misinformation, to Bob's point, one, are on social media, but actually when you get to the origins are related to 12 entities, likely 12 individuals. And so that just reminds us that, I like to kind of say that right now the Delta variant is so infectious that if I get it, a year ago, that same strain, I would have probably given it to like 2 or 3 people. Today, I would give it to probably 5 to 6 people. That information from one person can get to millions of people. And so it has not just this amazing ability to do what we call exponential spread, but what I would say is exponential damage as well. And it's hard. And so if anybody's looking at social media, WhatsApp, Facebook, Twitter, TikTok, I do it myself, by the way. I have to stop and say, what's the data to support that? Or what's the evidence behind this? And you don't need to be a PhD or a scientist to ask that question. And if you can't get a response, then you should actually say, like, okay, you don't have to get into it on the internet, but you should question that and you should ask the question. And I think hopefully coming out of this, whether it's respect for science or not, hopefully we'll have a public that wants to understand kind of fact versus fiction. I've had to teach my 6-year-old, what's a fact, what's fiction? And I never kind of really thought about teaching my children that, but I realize it's kind of what we all need a little bit. So, do your part. The audience that Bob and that Jeremy have is so special because you are trusted messengers. Sometimes that message is wrong. I will say the best thing I did, and we'll get to all these questions. I think about my posturing in February of 2020, and I didn't think, kind of like Dr. Fauci and others, that we needed to wear masks. I have wholly admitted that I was wrong, that we didn't press on that enough, and that could have cost people's lives. And so I think doing that is also, it's okay if you spread something on social media and liked it, but then you realize that actually, no, that's probably not true, and kind of own it too.
I think in first of all, I almost feel like if there's something that's unclear to me, go to your actual doctor, because this is all about medicine and science is really what vaccines are all about. So if you really want a good source of it, if you got a friend or one that you've known forever, go and ask them about it if you have time to, but that'd be a great way to do it. But the thing, when you look at just the life of social media, credibility is not the one that makes you money. It's attention, and so we know that the best way to get people to watch you and pay attention is to do something wacky, kind of different and unique. So the boring science facts out there are not making a lot of money and a lot of attention. So I think that's why it's there.
Absolutely, and that's unfortunately true. I just found, just to add on, right before we came on, I saw something about a study that came out from Indiana University, and they'd done a social media study, and it said 50% of respondents believe that the CDC is hiding negative effects about COVID-19 vaccines, and 25% believe that they cause infertility in women. And so it's definitely out there, and I feel like one way to tell the difference is if someone just makes a bold statement and then that's it, and they put it out there, maybe question it. Whereas, Dr. Patel just had that question about infertility, and went into I don't mean this in a bad way, but like a long answer with some qualifications, and here's what we know and don't know, and the things that are coming out. And that's generally when I feel like you could be like, okay, I feel like she's trustworthy because she's putting it all out there. Victor, was there any more?
Oh, that's it for now. Thank you so much.
Excellent, thank you. It did remind me of 2 questions. One here that it comes because I got the J&J vaccine, and we haven't heard nearly as much, and I know it's because many fewer got the J&J vaccine, but I think, am I correct, that it's proving to be relatively just as effective as the others in providing protection against COVID and the Delta variant? Is that correct?
Yeah, that's correct, Jeremy. So let me just, we actually have the most data about efficacy against the Delta variant from Pfizer, and that's because the country of Israel predominantly used Pfizer, and Israel also has been pretty vigilant about monitoring all breakthrough infections. And if I could criticize, to kind of that point you made about CDC hiding things, it's not that the CDC is not hiding things. In fact, the adverse event reporting system is public. You can go on it today and now and look at everything because it's people like me who report into it. and patients who report into it. But what the CDC has not done, they have stopped monitoring breakthrough infections that do not lead to hospitalization or death. So we have a bit of a blind spot about breakthrough infections that are not severe. But the reason I think they're important, and what's a breakthrough infection? It's someone who gets an infection with COVID, positive test, that's had a vaccine like you have. And I think it's because we're not monitoring that, we're not really getting as robust a sense of things like the country of Israel did, where they predominantly used Pfizer. We know that Pfizer, from the data that's available, is quote unquote highly effective, somewhere in the 80s to 90s. And then we know that because Moderna uses the same technology as Pfizer, we're making some assumptions, although Moderna's got some data as well, that it's similarly as effective. J&J is sitting out here, and I'll be honest, I think, so there's a trial right now where J&J is looking at 2 doses of the same vaccine, and that's possibly what's showing to be kind of more effective. And that's likely what might happen to the J&J vaccine of the future, like 6 months from now, everybody might get 2 doses. Having said that, your 1 dose in some very early trial data that is what we would call lab-based data supports that the Johnson & Johnson vaccine is indeed effective against the Delta variant. What I would say to anybody listening, or Jeremy, even you, not knowing your medical history or anything like that, that if there's also a chance that you're in that 5% that might have a reduced immune response, then you might be even more kind of like likely to need a booster shot. And it wouldn't be a booster with Johnson & Johnson again, it might be a booster with one dose of the mRNA vaccine. So you're bringing up a great point. And I think Bob was very kind, but I think this evidence is true, that have that conversation. And I'm going to double down and say with a physician, not because our advanced practitioners are not good at this, but I had to go, I have a public health degree too. A lot of us have had to go through epidemiological training to understand how to read some of these studies. And I think that's a good place to start. But if you've got J&J, feel safe, but don't hesitate to kind of call the question if you're worried that you did not develop a sufficient immune response. And I do think that given the 2-dose trial data that's going to emerge, I do think that maybe I don't know exactly how many months from now, the J&J COVID vaccine of the near future might be a 2-dose vaccine.
You know, I went over to, it's one of the few overseas trips I've done since this whole COVID thing started, because it's always been my thing that I've always do. I went to Turkey because Turkey was, Turkey was getting nothing. And so their only source of vaccines was a Sinovac coming out of China. And, that's like these things are being used as a kind of form of leverage in some ways politically from countries. But it's interesting, in Turkey, everybody we talked to had this great chance finally to take a vaccine, and they're all begging if they would like. They wish they had an mRNA. You have like a Moderna or a Pfizer. That was their dream to get that. So we've got the best ones in the world, and there's a lot of people getting vaccines from other companies, but they're really not as good as our 3, including J&J.
No, that is a very good point, and one definitely shouldn't forget. Somehow we're already at 4:52, so I don't know how quickly how that time went by so quickly. But I want to throw out a couple more things, but then also give both of you a chance to address anything that you want to address that we haven't gotten to. And this can be as quicker as fast as quicker as short as you want. One, we have talked about children. Any sense of when a vaccine might be available for those under 12? I think that's where things stand now. And then I just forgot my second question, so I'm going to leave. I'll come back to it if I think of it.
Yeah, I'll be brief. The pediatric trials are ongoing, and Pfizer kind of boldly announced that they should have data ready for submission to the FDA by September. If that indeed happens, the FDA will, this isn't the same thing as kind of the approval of the vaccine that exists. They treat it really kind of as a totally different product, because children are not little adults, and the metabolism of children under the age of 12 is different. It's not just it's not just by weight or by height. And so that data should read out from Pfizer in September, and then you usually tack on at least a month. You've heard now some headlines in the media about the agency saying midwinter, but this goes back again to like the timeline for the full approval, that the agency has more months than it's been taking, but they're doing it as fast as they can. So I think optimistically, I would expect an option for, let's call it 2 to 12 years of age by October, November. And then under 2 is also trials are ongoing for all 3 manufacturers, but we especially kind of have like a different process for thinking about the data for under 2. So I am hopeful all children will have a point of access to vaccines this year, but likely at the end.
Excellent. And I remember now my other question. And we talked about this when we were talking yesterday, and I also is making me think of, because we're hearing more and more of it coming out around the Olympics, and that is people testing positive even when they've had it. So kind of a very open and broad question. Asymptomatic carriers, and are we still focused on testing, or should we be more focused on testing? Like, I feel like that's kind of dropped out of the conversation. We're only talking about vaccination, at least within the US. I feel like we're not talking about testing.
Yeah, good. And I am going to insist that Bob have the last word, because you bring such comfort to me personally, watching kind of you and your reporting over the years. So I definitely want him to have the last word. So I'll take the super technical question. So number 1, breakthrough infections are expected. I mentioned that we have a blind spot because we're not necessarily gathering the data in a systematic way on all breakthrough infections. But the point of these vaccines was to prevent hospitalization and death. So let me be clear, it was not to prevent you from catching the SARS-CoV-2 coronavirus. And think of it as the flu shot. You know, you hear people say like, I got the flu shot, but I still got the flu. That's because what the shot's supposed to do is prevent you from dying. So these shots are doing that, but that doesn't mean they prevent you from getting an infection or a breakthrough infection. And the $1 trillion question is, if I get a breakthrough infection, but I don't get sick, could I still get someone else sick or give it to them? And with Delta, we think it's possible because it's so many copies being reproduced in my body, even if I don't get sick. And that brings up your very important question about testing. I encourage everyone to know how to have access. I bought a 10-pack of Abbott's tests from CVS because I got them on sale, and they're rapid antigen tests. Are they perfect? No. But if you are concerned about you or contacts and you do them over like 3 days, several each day, and they're all negative, pretty likely to be not infected. But that costs money. There are free and available tests. Insurance companies have to pay for it. Make sure you know how to get it. We are doing an all-time low in our numbers of tests. We are doing about 500,000 tests a day. That's not enough. States like Florida, where there's an 11% positivity rate, we probably are not testing people to the extent that we should, which means we're not picking up as much infection as there likely is. So, you know, I see a lot of coughs and colds. We're seeing a lot of what we call the respiratory syncytial virus, which we normally don't see in the summer in kids. I'm insisting all my patients, even with sniffles, get tested, because we just don't know how this virus might present. It might not classically present the way it had a year ago. So, you know, don't be scared, and don't think that it's that, you know, test that goes all the way up into your brain. I've got easy ones that kind of, you know, I can do on the nose, and then we're developing pinpricks and saliva. So they're not painful, and encourage everyone to know how to get tests or get some in your house yourself.
I've done so many of these tests that I can take them easily. You know, whoever thought you could take something?
You can do it like it's you one. You don't need anyone else. You can do a one-person testing machine for sure.
Listen, my thought is just like the more information we have, the more we know about the people that's next to us. I think that brings you a lot of relief. You know, and how you feel you're safe, you're not safe. I'd like to know if the person next to me is vaccinated. Although I feel if I'm vaccinated, I'm not really afraid of even that. But I don't want to carry it for them to carry it somewhere, you know, to my kids who can't get vaccinated. I think that would be good. But the sad thing, this is the issue that's kind of loaded with policy or politicians, you know, and arguments and politics. Because part of it, for example, is the vaccine passport. You know, should we have a system where, you know, you cannot get in to a show, or you can't really come into the school? You know, the ability to prove somehow through real true science that you are vaccinated or you don't have the disease. You know, you go to the Olympics, people have to get tested. They need to know if people, before you go out there with no mask, sweating and touching everybody, you kind of have to know that you don't have it. Because now we know that even if the other athlete that's next to you has been vaccinated, you know, 4 months ago, they could still possibly get it, probably safely, but they could get it again. So I think we more need to have the information about it. So I'm kind of a big fan of testing. I haven't had one in a long time because I haven't really been outside the house as much as I used to. but I think it's important.
Excellent. Well, with that, that is perfect timing. I thank you both incredibly for being here, for your knowledge, your leadership on this. Bob and the Bob Woodruff Foundation is just an incredible asset for the entire veteran community. Thank you so much. And Dr. Patel, your knowledge, your ability to explain it so clearly and eloquently is incredibly helpful. Thank you. I hope to have both of you back on. Like we said in the beginning, maybe it'll be, a few months from now, and we'll be talking about all the trips that Bob's taken now that the pandemic's over, because I would love to have that conversation.
Jeremy, you should go into television news, man. You do a good job.
Oh, I say we take the show on the road. I know. Bob clearly doesn't need us, but
Right.
We're going to be on the road again. I want to be on the road.
just, yeah. Well, I think all of us are desperate to do something different. So
Exactly. I like it. I love that idea. That's a great way to close. Thank you all again. I really appreciate your time, and look forward to speaking again soon, hopefully in person.
Thanks, Jeremy. Thanks.
All right. Thank you. Take care.